How does their tear breakup change? Because Trattler promotes itself as being a different type of a non-BAK medication, and they're claiming to be better tolerated on the ocular surface. And so that was our study to determine whether that was true. Now this is a complicated slide, and I apologize, I did not design the slide. But the purpose here is to kind of look at the various scores. I hope you can see that. So the first box is the hyperemia scale. Then we have corneal staining in the middle, and then the tear breakup time in seconds, with the actual time and the change for all the medications for Lumigan in the first row. Then we have Xalatan and Trattler, and you can see that in all three groups, hyperemia was the hyperemia first, very low numbers, all less than 1, very similar in the groups, and very little change from the Xalatan baseline. Corneal staining was also very low in all three groups. Again, the change was very minimal, not statistically significant. And then lastly was tear breakup time. That's a very important test for looking at the ocular surface tolerability. You can see that the amount was pretty similar in all with one agent. That's the optimal goal. It's easier for compliance, for cost, and clearly the studies show that of all the available prostaglandin analogs, that clearly the patients that are on hematocrisis do get the lowest pressure lowering and seem to be the most potent and work the best. It seems to be safe, well tolerated, these multiple studies. And so overall, I think we're very happy with that in practice. I know some people showed up late. If there's any questions?
Dr. McCuley is professor and chairman of the Department of Ophthalmology at UT Southwestern and is currently entering his 30th year of chairmanship. He is a recognized expert in cornea, external disease, keratorefractive, and cataract surgery. He has published in the peer-reviewed literature over 260 articles. Today, Dr. McCuley will be talking about the role of aqueous tear evaporation in dry eye.
Thank you. Well, as stated, I'm going to talk about aqueous tear loss through evaporation. This is something that I got interested in, decades ago when I was a fellow at Boston in Boston. And what I recognized was that patients with meibomianitis appeared to have a lipid abnormality causing major layers of the tear film. And I'm going to come back to that in a moment. We know that the tear film is extremely complex. There are many, many different molecules in each of the layers. And these molecules often will interact with one another, and either the absence or excess of the interaction of the molecules can disturb the tear film in any one of the three layers. I've spent most of my time looking at the lipid layer, and the principal function of the lipid layer is to prevent evaporation and overflow of the tears onto the lid. And it's, in effect, principally an anti-evaporative layer. Now, biochemically, we've looked at all of them in combination. There's about a 99% increase in an aqueous tear loss through evaporation when we decrease the relative humidity by 20%. So here instead of the aqueous tears are lost or turned over through evaporation, the remainder down the nasal lacrimal duct. This is a remarkably large amount of loss of aqueous tears through evaporation. The anti-evaporative effect of sustain is very real. It can decrease the evaporative rate 12 to 16% depending on the relative humidity in which it's being measured or the tears are being lost. This also, in addition to its therapeutic role, brings the possibility that it might be wise to use it prophylactically when we know we're going into an environment with very low humidity, airplane cabins, deserts, windy situations, high altitudes. Now, there's the studies that have looked at the osmolarity of the area in the pathogenic phenomenon. In managing meibomianitis,